Good morning, everyone. Welcome to Pediatric Grand Rounds, and thank you for joining us today. Today we have a special program, and we'd like to acknowledge the generous support given by the American Academy of Pediatrics Section on Breastfeeding Education Grant Award to bring Dr. Ann Kellams to us. I'd like to say a special thank you to Dr. Cameron Johnson for her support in applying for this grant and for planning the workshop that most of the residents will be at this afternoon. All right. Dr. Ann Kellams is a professor of pediatrics and vice chair of clinical affairs in the Department of Pediatrics at the University of Virginia. She has served for the last 12 years as a medical director of the Well Newborn Service and helped found and is the current director of the UVA Breastfeeding Medicine Program since 2011. She's a graduate of UCSF School of Medicine and completed her pediatric training at Chapel Hill. I will not say the year. She serves as the executive committee of the American Academy of Pediatrics Section on Breastfeeding and is currently the president of the Academy of Breastfeeding Medicine, a physician organization of over 1,000 members worldwide. Her research is the area of parental education related to infant feeding, hospital breastfeeding support, and safe sleep practices with the SMART, School, Smarter, and Supersonic grants funded by the NIH. She has multiple peer-reviewed publications and chapters in Pediatric Up to Date and Neonatology for Primary Care, to name a few. She also serves as a scientific advisor for the Virginia Department of Health Breastfeeding Friendly Consortium that offers free web-based CME and MOC to Virginia residents. Please join me in welcoming Dr. Ann Kellams.
Hey, thank you so much for that introduction and for having me today. And I do want to shout out the AAP section on breastfeeding for supporting this and lectureships all over the country for the education of pediatricians to help make their lives better. So I'm really, really pleased to be here. By way of disclosures, I always start with I do not accept any funding by the makers of breast milk or formula for that matter. I'm going to reveal my age here. I've been a pediatrician since 1998, had my 3 children, and then became faculty at the University of Virginia. And as she mentioned, I was medical director for the newborn service for a number of years, helped start the breastfeeding medicine program at UVA, which we just celebrated our 10th birthday. And I've been an IBCLC since 2007. As she mentioned, I'm president of the Academy of Breastfeeding Medicine. And I'm gonna be honest with you, I was not prepared by my training to help people with breastfeeding or to help myself breastfeed, but I thought I was. And then I finally got goodish after about being an IBCLC for 3 years. And so that's just to say that a lot of the things I'm going to be talking about are the things that I wish I would have known or I wish I would have learned. I absolutely will talk about breasts like crazy. I gesture, I talk with my hands, I blame my mother, and that's going to happen during this talk. And then I also want to do a shout out because I'm going to say mother and breast and breastfeeding a lot, but with the understanding that not everyone who breastfeeds or chest feeds identifies as female or identifies as having breasts. So I'm going to throw that out there right now, trying to be inclusive. This is the objectives, which, yeah. And then let's start. So I like this article because I've kind of gotten a little bit into qualitative research and sort of mixed methods, and you really get richness when you do qualitative research. And this was something published in the Journal of Perinatal Education a couple of years back, many years back now. But they just asked health professionals, like, what do you know about breastfeeding? What's hard about it? What makes it work? And it's very interesting because there were 4 themes that emerged, and one of them was just sort of lacking the current knowledge. And I think I can say the same thing about myself. A decade ago, that I just didn't know that this whole science and body of literature existed, that it really does make a difference how babies feed, and it really does set up their microbiome and sort of lifelong health and optimum growth and development. I was not taught some of this, and I'm going to say today, some of what I was taught turns out to not be correct, and I know that happens a lot in medicine. I don't have the skills or the time, or, you know, how do I really know if it's going well? It's so much easier. We all sleep better if I can count the ounces and, you know, that sort of thing that the baby consumes. And then I know it's important, but what can I do about it? You know, I'm one person, I've got this mom, she's already decided, you know, that game over. So that's kind of the approach that we're going to take today. And this is just a reminder, and I heard that you all have already had a grand rounds or something about why it's so important. But I just added to this slide from it actually comes from National WIC, which is, you know, there's also living cells and stem cells, and there's anti-cancer fighting properties, anti-inflammatory properties, and now we know so much about the microbiome. So just, you can't put that in a can. And then there's a lot of literature emerging about the health benefits for mothers. So I think as pediatricians, we care about the whole family. That's something that I love about our field. And so just thinking in terms of the health, not just of baby, but also of mom. So question for you all, and I know there's a virtual audience as well, but, you know, just I want you to think about and maybe chat in, what are the most common challenges that you face daily in supporting breastfeeding or in the management of breastfeeding? And I'll give you just a second to do that. And then I'm going to show you on the next slide what I'm guessing people are going to say, because this is what we see all the time in breastfeeding medicine clinic. And by the way, this is me, the older child here, breastfeeding my baby next to my baby sister, who was born about 16 months after me. But I think a lot of us have a lot of sort of questions and unknowns, and what if she's having pain? Is that okay? Is that not okay? Everybody's worried about, do they have enough milk? What if mom wants to use formula? What if the baby doesn't want to go to the breast? You know, those kinds of things are so common. So we're going to try to bust some myths. This is in random order, and I'm going to try to show you some of the science too in a very quick fashion, because I want to get to a lot of material about why some of these things maybe that we were taught and by convention, and this is what we've always done in pediatrics, need to change. So the first myth I want to combat, and I want to encourage all of you to basically, and you know, never say never, but I never want you to say you need to feed your baby X number of hours, because every time, even if you say at least, what happens is they hear that number, and then when the baby's hungrier sooner, they think, well, I just fed you and it hasn't been 2 hours yet, so I'm not going to feed you again. And that's not how milk making works. So we really don't want them to be watching the clock. You can say we want baby to feed 8 to 12 times a day, and we want that to be set with baby's sleep cycles and wake cycles, not by the clock. So we know that especially in the beginning, that those liquid gold drops of what I call concentrated breast milk, that they do need that very frequently. And we also know that frequent attachment and signaling is what tells mother's body to make more milk. So if baby has taken their X number of drops and an hour and a half later would like to have some more, we want to do that, and that's how mom's body sets to meet the needs of the infant. This is a study looking at, it's cool because they used a digital app. They looked at newborn sleep cycles, and it turns out, as we probably know, that they cycle through sleep very, very rapidly. This involved 277 children that were 0 to 2 years of age. I'm focusing just on the 0 to 2 months from this graph here. 22,000 recorded sleep sessions. And the parents were just asked, when did your baby fall asleep? When did your baby wake up? And you can see that from birth to 4 months, what they found is there's a very high frequency of short sleep sessions. This is the raw data here, and then if you look at this heat map, here's 4 hours. Very, very rare to go past 4 hours naturally. So even if you have a sleepy baby, and I have a slide about this Oh, let me just say this first because that's the order I put these in. We call this responsive feeding, feeding on cue, feeding on demand. I don't like the word demand because there's not a demand. There's just a physiologic, biologic need, right? So we just want to respond to the baby's cues. So hungry baby is rooting, their hands are up, their fists are clenched, they're sort of tense and tight, and a full baby, even if it's from a few drops, because that's all they need initially, the arms relax, the hands open up, they're content, at least for a time after the feeding. There's some data to show that they have more stable blood glucose levels, they pass meconium more often and faster, they have increased breast milk on day 3 if they're fed on cue or with responsive feeding. And why do we think that is? I think it's signaling. I think if they go to the breast whenever they want, mom is actually producing more milk on day 3. They get back to their birth weight faster, and they're also more likely to be exclusively breastfeeding. So really, really important to feed on cue.
Dr. Kellams, we have a question. It says, how does the nutritional content of colostrum compare to mature breast milk?
Oh, I didn't put that slide in, but we can talk about that. It's basically very, very concentrated. So it's like, those old, I'm dating myself, orange juice cans you buy in the freezer section. It's like that. And babies are born with extra water, so they do the mixing themselves. That's the way I talk about it. So if there's a sleepy baby, I always get this question, what if it's, a 37-weeker, they're early term and they're sleepy? No problem, but then we just be very careful not to have a lot of artificial comfort. So here I've got a grandparent snuggling the baby, don't want to miss those feeding cues. Here's the completely swaddled, and yeah, if it's been 3 or 4 hours and they're being artificially comforted, then let's unswaddle the blanket and let's change the diaper, or let's have an awake mom hold baby skin to skin. And then by the way, we're going to be watching. Our job is to watch and make sure this is happening and that it's safe and that things are changing with mother's body and milk supply just right in time for when the baby needs it. We're going to encourage skin to skin when mom is awake, and babies that are skin to skin will eat more often. We're going to teach her how to do hand expression and breast compression. So if the baby is not rousing and doing active suckling and swallowing, we're going to help and provide that signaling and get that into the baby. And then we're going to teach them to listen for swallowing, which is not something that we're just born with that skill and that knowledge. I always tell parents when they're worried, and especially if they've spent time in the NICU or something, they're very I set my timer, my watch, and very, very fixated on time. I say, you know what, I love to eat. I love, love, love food. And if you brought me my favorite meal at 3 a.m, I would look at you like you're crazy. And so we're going to have better feeding attempts and more vigorous baby who's interested in learning how to eat when we wait for them to cue. So I think that makes a lot of sense. All right, myth number 2. How many times do you hear, oh, I tried breastfeeding and I just didn't make enough milk? It's actually very, very uncommon. And we don't have great data, but we do have a lot of sort of anecdotal evidence surrounding things like times of war and disasters. And even mothers who've been feeding only formula can relactate and meet the needs of their baby. And it's very, very, very few babies that would need to, feed with another mother's milk or that don't survive because there's not safe, clean water supply, etc. So most women can produce enough milk if they get optimal care, they have realistic expectations, they get advice, support, and management. And we can also identify who is at risk of not making enough milk, and we can proactively sort of intervene and take steps to maximize their support. So this is an example of, it's actually from an article from Pediatrics that I was one of the co-authors for. If she has a very high BMI, or she's had issues with insulin resistance or PCOS, previous breast surgeries, these do not mean they can't breastfeed, but it means they may be very, very signal dependent. So some mothers have their babies and make milk for quintuplets without thinking about it, and other mothers are dependent on every single signal, just like some of us can run a marathon and look like we didn't even sweat, and I can think about running a marathon and look like, drenched. So it varies from woman to woman, but if you know you have somebody that has a risk factor, then you're going to be doing extra signaling from the beginning. I want to show you this picture, and I want this to sort of burn in your brain. Some of my saddest experiences in breastfeeding medicine clinic have been mothers who have breasts that look like this, that are hypoplastic, that are insufficient glandular tissue, have gotten all the way through pregnancy and their hospital stay, and come to me at 2 or 3 weeks because their babies are feeding only formula, and they're pumping, they're getting 3 milliliters, 2 milliliters, 1 milliliter, sometimes nothing, and they have insufficient glandular tissue. This is a very, very rare condition, but this is somebody that if they want to breastfeed, they're still going to make colostrum, and that's still really, really good for baby. So we're going to teach them about comfort suckling and about transfer of colostrum, maybe supplementing at the breast, maybe doing a mixed feeding type thing. But this is these widely spaced, sort of triangular kind of curve in between the chest wall and the nipple areolar complex. This is insufficient glandular tissue. Another thing I'll just say about that is that this happened to me recently, where you have a mom who's had breast surgery before. Ask why, because if she's had implants, it might have been cosmetic, or it might have been because of body dysmorphia, but it might also have been because of insufficient glandular tissue. And so this was the case. And she said, no, I just had one breast that just never got as big. And I said, did you feel like it wasn't, didn't have as much tissue? And she's like, no, I don't know about that. It was just smaller. I showed her this picture, and she said, that's exactly why I got implants. And so that's a different conversation. We also know that things that happen in the peripartum period can impact supply. Medications during labor that can have a sedating effect on the baby. Guess what? Limited signaling, because the baby's not feeling it. They're relaxed. They're artificially relaxed. So we got to step in and do some signaling. We know that super prolonged labors and long inductions of labors can impact both feeding behaviors early on and also the success with breastfeeding. So we want to make sure. Peripartum hemorrhage is another great example. We know the watershed effect in the brain, or Sheehan's effect, can cause a delay in lactogenesis stage 2. There's some neonatal factors, like did they get separated? Is there a tongue tie or any other sort of neurologic issues that change the baby's tone or coordination? And then intention is very important. So ideally, we would be having every mom who's coming into the hospital having already heard that we recommend breastfeeding, how great it is, what to expect, and that they're planning to breastfeed for at least 1 to 2 years. The AAP breastfeeding and the use of human milk should be coming out soon, and it's going to be more in line, I'm predicting, if it gets through all the right approvals. Should be released in the fall. It's going to be more in line with WHO recommendations of 2 years. So we're really, there's enough data now to say that even longer is better. So this is just basically a summary. If you have somebody who's at risk of not making as much milk or is particularly concerned, don't miss opportunities to signal. Keep mom and baby together. Feed on every cue. Making sure from the beginning, and we're going to talk about this more, that the latch is comfortable for mom. Pain is a signal that something is not right. It is not okay to push through pain, and I'm going to try to convince you of that by the end of this talk. Consider supplementing right at the breast so that baby gets what they need while we're waiting as a bridge until mom's supply is up. And then if formula is being used, make sure she is providing additional signal, because her body only knows how much milk is removed. And signaling beyond her supply is going to tell you to make more. So if she gives what she has, baby takes formula, her body thinks we're making the perfect amount. The baby hasn't come back hungry and we don't need to make any more, and that's not true. So if you're using something other than her fresh milk, you have to signal. This is a little bit showing that, we can get really technical here, but babies suckling causes changes in mother's brain, which then says make more milk. So prolactin and oxytocin, don't forget oxytocin is the love hormone. So you take an anxious, worried mom and give her some oxytocin every couple of hours. I tell you what, that impacts bonding and well-being. Specifically, we want to avoid the downward spiral. So she feels like she's not making enough, and then she gives a bottle to top off the baby. Even if it's after breastfeeding, baby gets full, they might sleep a little longer, maybe they're not as vigorous with the next attempts, or maybe they're not feeding as often, and then she makes less milk because there's more signaling, and on and on and on. It's very difficult to break that cycle. So we need to be thoughtful, and we need to be honest about sort of an informed consent. When you're starting down the formula pathway, they need to understand that that could hurt their chances. And then if they still want to do it, let's do it in a way that can help preserve breastfeeding. So takeaway points from this one: if baby's eating anything else than mother's fresh milk, there has to be signaling. And if supplementation is required, don't forget to say, well, how did we get here? Why is the baby not getting enough, if that's really true? And let's fix the problem so that this is a bridge back to breastfeeding. All right, myth number 3, it's really hard to tell if a breastfeeding baby is getting enough to eat, and I'm going to try to bust this one for you. We actually have a lot of ways to see if it's progressing, and we're going to talk about those. We know that it is very normal to have very little intake because of that concentration of the breast milk. You can see that this was a study looking at both vaginal and cesarean deliveries, and that this is mils per kilogram of body weight on day 1, and we're talking like maybe for the whole day 10 milliliters. So very, very concentrated, and then you can see it goes up. By day 4 to 5, we would like for the breastfeeding person to be reporting that they've noticed a very big change. Either there's some swelling, there's some tenderness, they're fuller, they're more firm, they're seeing more milk. But by day 4 to 5 is when we'd like to see those big changes. This is something, it didn't come out quite as well when I cut and pasted it into PowerPoint, but this is something, a chart that we have hanging in every wall, and it goes a long way to help set realistic expectations, and also just for the parents to understand that we can look at the baby's behavior, and we can look at their output, and the changes in mother's breast in addition, and that the expectations change every single day. And so, really looking for about 1 wet diaper in the first 24 hours, kind of 1 for every day of age until, like we said, by 4 to 5 days, we're talking 5, 6, 8 wet diapers a day. We want baby to feed often and to have some strong, steady suckling. And we want them to be able to wake and move around and have a strong cry. All of those things are indicators that they're doing well. We also want them to settle after they feed each time. So cluster feeding is normal, and by that I mean feeding frequently, more than every 3 to 4 or 2 to 3 hours is normal. Not settling after a feeding, even for a short time, is not normal. We have lots of tools now to track their weight. The Newt tool, if you're not familiar with it or you're not using it, I highly recommend it. You can just go to newbornweight.org. It actually gives you from 0 to 30 days, depending on the type of birth and how the baby's feeding. It will give you a nomogram or a curve showing you how much % weight loss on day whatever, and it actually goes by the hour, you would expect. And so if I have a baby that, we're worried, but the output's been great and they're acting fine and their exam is fine, and I plot their weight and it's like less than the 75th percentile for weight loss, I'm feeling pretty good about that. So, and pediatricians are used to growth curves, so we like that. And then here's my checklist. Going to the breast or mom is expressing right after birth in the first hour or two. This is predictive of later exclusive breastfeeding. Baby's having the output that we expect. Mother is not complaining of nipple pain. She may have seen drops of colostrum, which is not required, but it is reassuring. Baby is waking, frequently to feed and seems content after. There's at least 8 times in 24 hours. We're hearing swallows. If the baby is not yet consistently latching, that can be normal, but we're doing something to signal. If the baby is preterm, mom is also helping express milk every time. So I don't expect babies to be great breastfeeders until they're 1 to 2 weeks past their due date, which means if you're born at 35 weeks, even if you look like a big kid, you need some help. And we're just going to assume that you need some help for the first few weeks. So don't set up the expectation, oh, that looks great, and then send them out because they're going to need help. The weight is looking good on NUT, and of course on exam, everything is looking great. Mucous membranes are moist, they have good skin turgor, they're active, etc. These are some maternal conditions that would need a feeding evaluation and or intervention early on. And by that, I mean in the hospital, they might need a prenatal consultation and then frequent follow-up after. But certainly if she has any of the risk factors we talked about, if she's worrying about how much she's making, if she has soreness of her nipples or nipple compression, if by day 4 to 5 we have not noticed any changes in the breasts, these are all reasons that I would be paying extra attention to this dyad. And for myself that works at, Quaternary Care Center where we get a lot of referrals, we have a lot of this going on. So pretty much it's rare to have a breastfeeding baby that doesn't require a little extra attention in the hospital. And then infant conditions. If they're still sleepy, difficulty latching by day 3 or 4, hopefully we've been signaling and making up for that. But then I'm starting to say, hey, what's going on with you that you're not, this isn't clicking in, especially if they're born at term. Younger, earlier gestation babies may take a little longer. What about if they're ineffective or they can't sustain the suckling or they're not getting consoled? That's a red flag for me to figure out what's going on. We talked about the weight loss. If they're leaving the hospital supplementing or they're needing a pacifier early, like the baby is so inconsolable that they need a pacifier, then is that the baby that's not getting content after feeding? That would be concerning. And then of course, any clinical signs of dehydration we're watching for. In terms of timing of the assessment, and again, this is in the article published in Pediatrics, we really recommend that once a shift that somebody has observed a breastfeeding, it doesn't have to be the entire breastfeeding, but we can observe that mother is comfortable with the latch, we're seeing active sucking and swallowing, we're hearing swallowing. We would like that to be documented in the chart at least once a shift. And then within 8 hours of going home, and I'm sure it's happening here, but across the country, and particularly with COVID, we're like, oh, great, first time mom, 35-weeker, you can go. Like people are just in and out of the hospital so quickly. But it's on us. You can't send a baby home that hasn't adequately accomplished a feeding yet. So we need to be paying close attention to that. Sometimes I have to argue with my OB colleagues a little bit who are just ready. Mom's okay. And I'm like, no, we can't go yet. And then following up very quickly after discharge, because again, we want these moms to be breastfeeding. We also want to be careful that everything's happening and progressing as it should. Babies who are early, like we talked about, if they're having any difficulties, if they're leaving supplementing, if we're worried about jaundice risks or they've already presented with jaundice in the hospital, or if they're leaving before 2 days of age, then we really recommend within 1 to 2 days that they're seen, have a weight check, have a belly check, have a feeding observed. Be careful with those babies with risk factors, because they may need a visit every 1 to 2 days until breastfeeding is well established. And what we consider to be well established is that mother has gone through lactogenesis stage 2, so we've gone from drops of milk to ounces of milk. Baby is in a good weight gain pattern. We'd like to see the nadir at day 4 to 5 and then start going up, and you'll see that reflected on the Newt curve as well. We'd like baby to be waking up and cueing to feed. Caveats for those late preterm babies that they might need a little more unwrapping and a little more skin to skin, a little more encouragement, but we want them to wake up and be interested in eating. Mom is comfortable. Once she gets through the engorgement phase, feels like her breast feels softer or lighter or more drained after the baby eats. And then by 2 to 3 weeks, 95+% should be back above their birth weight. What to supplement with always comes up, and the Academy of Breastfeeding Medicine has a protocol related to supplementation, and always consider using mother's own milk first. And so that might go back to the signaling. If she has milk there and baby is not effectively getting it, let's just help baby get it out and feed them that. That's going to be your safest and your healthiest and your most effective. A lot of hospitals are moving to pasteurized donor breast milk, even on the term newborn service. Protein hydrolysate formula, there's a little bit of conflicting evidence about whether or not that helps decrease the risk of cow's milk protein allergy, but that's something to think about. But all of those things before you think about standard infant formula. And then if supplementation is used, make sure the parents leave the hospital knowing how to safely mix the formula. The CDC has a nice handout and demonstration. WIC has a nice one, but make sure they know. And then try to preserve breastfeeding with keeping those latching attempts going, making sure mom's doing the signaling to make up for whatever we feel like she's not been making sure that feedings are observed, lactation consults, professional help in that way, breastfeeding medicine clinic. Have an endpoint, like as you start making more milk, then you can go down on the formula. Or I'm expecting that since your baby's 37 weeks, we might be doing this for 2 or 3 weeks, but then it's going to end such that they don't feel like they're in this swirl of the triple feeding saga that with no end in sight. Think about limiting the amount to physiologic volumes instead of just glug, 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 glug with gravity. We talk a little bit about paced bottle feeding, and I have a slide about that later. But if they're going to do bottles instead of an alternate feeding method, then let's make sure the baby's learning, I've got to open my mouth after I root around, and then I get milk once I start suckling. You don't want to put milk in their mouth to get them suckling necessarily, because that's not how all the breasts work, right? Here's a sweet baby who's breastfeeding and feels it's so important that even when you're on the potty, you can do it. Okay, here's another question. So if you have a mother who is having nipple pain with breastfeeding, what do you think you should do? Should you reassure her that that's pretty normal, especially at the beginning? Give her some nipple ointment, observe a feeding, try to let some milk dry on her nipples to help with the healing, or go to nipple shield? And I'm gonna show you the answer here. Observe a feeding, because we can fix this. So we're gonna talk about this. Here's myth number 4, and this one is probably the most common chief complaint in breastfeeding medicine clinic is pain with feeding. Nipple pain is normal, especially at the beginning. It absolutely is not, and I'm 100% convinced, and I probably wasn't 100% convinced, again, until about 2010, so 3 years after becoming a lactation consultant, because even in my training for lactation, it was like, oh, if the pain's at the beginning of the feeding, that's okay. It really isn't, and I'm going to show you why. So think about the nipple as having about 14 straws in it. And if that nipple is getting rubbed, which would seem like it would be impeding the opening of those straws, or compressed, which would be closing the straws every time the baby suckles, that is not going to allow for good signaling and good milk transfer. So what we really want is this, and we want the pressure of the tongue and that rhythmic motion to be here, not here and not here. If you ask moms who have nipple soreness, where is it hurting? Show me with your fingers where it's hurting. Where'd my cursor go? Invariably, it's right on the tip. I mean, like, invariably. There's some pump traumas down here and occasionally a natal tooth or something that we need to work around, but it's usually right here. And that means baby's tongue is doing something we don't want it to do. And I'm going to show you some pictures. So there is a fix for it, and it's going to be getting the baby's tongue, which is what's doing all the damage, further back from the nipple as they get on. So it is not taking baby's mouth and target sign. It is very, very asymmetric. This is just showing some damage on the tip. These are the stripe appearance of the damage. And here is actually a compression stripe. So baby just came off the breast and you can see this blanched area. This means things are happening that we don't want to happen. This is ultrasound, real-time ultrasound, a lab I want to visit, but I haven't yet. And Dr. Hartman just passed away this past year. But Peter Hartman, Donna Geddes in Western Australia have a breastfeeding lab, kind of like a sleep lab where there's all these like electrodes and they're tracking oxygen and energy expenditure and real-time ultrasound. They put a probe while baby's breastfeeding kind of in their chin right here, and they look. And what you see is, here is mama's nipple. This red line is the hard and soft palate junction. So feel with your tongue behind your front teeth and go all the way back to where it's squishy. That's where mom's nipple goes, okay? Here is the tongue, and this is the peak of the wave. And so the tongue is going to be making this wave-like motion here. The peak of the wave does not compress the nipple, and nothing is touching the tip of the nipple. So if you have scabs and soreness and bruising here, that tongue is peaking here instead of here, okay? So this, to me, like, case closed, we have our answer. No nipple pain or compression or rubbing or irky feeling while breastfeeding. There is a very easy way to fix this. I will tell you that a lot of mothers, like when you're sore and you're seeing that baby's mouth, it's hard to imagine that they could attach without it hurting, right? But it is possible, and I have helped people whose nipples honestly look like hamburger meat, and you get that baby on in the right way, and they go, oh. And I say, how does that feel? And they say, it feels like cotton or nothing. And so I actually don't let people leave my office until they've had this aha moment. And sometimes it takes an hour and a half. But we want her to believe that that is possible and feel that that is possible. And as soon as baby is not clamping down or rubbing or compressing that nipple, it is so much more comfortable. You want to tuck baby against the chest of mom, no matter what position they're in. I do not teach positions because I want mom only thinking right brain. Pain, no pain. If I feel pain, then I'm mommy cow in the field and I go, get away. And then the baby's gonna have to try again because it's just hurting or not hurting. Can I tell from looking if it's a good latch? No. 50% is, how does that feel to you? And we're asking them that over and over and over until we hit it. And if it's still pain, no problem. Tuck baby in a little more, get their chin a little further back. Let's try again. And we do that until she can reproduce that and until she feels that, oh, okay, that feels really different. So I can't emphasize that enough. In a complete latch, and I have some pictures here, baby's mouth is very wide. It's almost 90 degrees. And I want to show you, here's Jonas. This is a friend of mine's baby with a breast model, and I do carry a little baby hat with a little nipple in my pocket of my white coat because it's nice to have a visual aid to help them understand. But so you're gonna start with nipples. See how the nipple's pointing up to his forehead or up to his nose? And then you're gonna kind of tickle, and as he starts getting interested in rooting, that nipple's gonna be pointing way high in mom's mouth, way up to that hard, soft palate junction. And then here is some video that I'm gonna show you. So this little guy does not, if you go from upper lip to jaw to lower lip, that's not almost 90 degrees. You can see mom has a ton of milk. This baby may be growing fine. The weight may be fine because she's pouring out milk and baby's swallowing it, but she has soreness. The baby's nose is touching the breast, the chin is touching the breast. This is not an asymmetric latch, nor are we having effective feeding. Look at the difference when we adjust the latch on this baby. Same baby. Look at the nose or upper lip to the jaw. Now we're much, much wider. There is no gap. The nose is barely touching. You cannot see the chin. See how you can see the tip of the chin here? This chin is buried in the breast. And we're seeing, I'm going to show you one more time, these, what I call these gagunk swallows, okay? So this is an effective feeding and mom is completely comfortable. Look how much areola we can see here. And hardly any. You can almost tell that the chin is covered all of the bottom. That's an effective feeding. So we are all born to breastfeed. Babies know how to do it. I'm not, in the interest of time, I'm not going to show you this video, but if you Google breast crawl, it is unbelievable how if you take a baby, even up to about 4 months old, and just put them right on mom's chest, you have to wait because it takes the average baby 52 minutes, but they can absolutely do it themselves. This is a great technique if they just can't believe that it's going to happen or they're so sore they don't even want to try. It's also a great technique if baby is refusing the breast and only wants the bottle because they've had it and it's easy and they're used to it and that's what they've imprinted as feeding, to just say, you know what, stop even trying to breastfeed and start doing 1 to 2 hours of skin to skin a day and then just let the baby explore. We want to activate all those little natural instincts. Looking and assessing for milk transfer is very important, and I'm going to teach you my techniques here. So this is sucking and swallowing pattern. This little is how the baby, this very rapid kind of shallow frequency suckling is non-nutritive, and it's meant to get to the breast to signal to mom's body with that oxytocin and prolactin. There's no danger here. It's okay to release this milk. And then you see suck, 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 suck at the beginning of the feeding, and then gugunk, gugunk. There's some nice swallows. So I've got, okay, we're started transferring milk. Here's a pattern that I might expect for a newborn when there's drops of colostrum. Suck, 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 one swallow. Suck, 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 one swallow. So this lactogenesis 2 has not occurred yet, which is normal in the first couple of days. This baby is transferring milk, but it's like every 4th suckle or every 5th suckle or every 3rd suckle. Here's a baby that suck, 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 pause and fall asleep, suck, suck, suck. This baby is not transferring any milk. And this is a baby that mom would need to be compressing or hand expressing, and we need her to know that before they go home. This is a baby where lactogenesis 2 has occurred, and they're going gugum, gugum, gugum. They're just like gulp, 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 swallow, 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 swallow. So we call this gulping. And if I'm on rounds in newborn and the lactation consultant says, oh, I went in room 43, they are gulping, and I'm just like, we are good, all is well. So that is what we're looking for. So this is just a summary slide. I'll make sure you all get these, but it's comfortable. I don't see evidence of nipple pinching or trauma. I ask the mom when the baby's attached, is this comfortable? Do you feel any nipple, anything? I kind of say I want it to feel like this and not this. No little anything that's nipple-y feeling. So 0 or 1 out of 10 maximum. We're hearing some swallows. Baby feels comfortable. They get that noodle arm or the milk coma, their hands release. That's what I'm looking for. I get asked often about nipple shields, and these are the indications that I would consider for a nipple shield. It's kind of like training wheels, and so a premature baby, we use this a lot for babies in the NICU to transfer to the breast. Sometimes babies that have breast refusal, we will try because it's a little stiffer and a little bit more familiar than just skin when they've sort of imprinted that this is not where I eat like this. So sometimes we'll use it as a bridge there to kind of trick the babies. Sometimes they're just so sore that they just can't even imagine trying to put the baby, and we'll use that while the baby is learning an effective latch so they're not doing trauma over and over and over. And then occasionally there's babies where mom's nipples, we talk about orobubular fit, and if she has flattish or even inverted nipples, sometimes if that mama has a baby that just wants their palate triggered before they start suckling, the nipple shield can provide a little stiffness to help trigger the palate. Here's a true or false question. Is there such a thing as nipple confusion? What do you think? True? What do you think, audience? True or false?
I don't think it's confusion. I think it's preference.
It's preference. Exactly. These babies are not confused. And I can say this now, I feel like the past 10 years I've done my internship and fellowship in sort of like veterinary medicine or something, but there is no confusion. They get there and they're just like, what are you doing to me? Why is this different? I'm cueing you that I'm hungry and you're not giving me the way I eat. And so they just prefer. Are there some babies that can go back and forth from the beginning? Absolutely. But do you know if you have one of those until it's too late? No. So we try as hard as we can, if we use artificial nipples, to do it in a way that is what we call paced feeding. So up here, you're going to see what we picture as bottle feeding, which is you hold the baby like this, you hold the bottle like this, and every picture that you see is going to show that. And it's actually really hard to find some where the bottle is more horizontal. So milk just barely in the nipple. I'm going to take that bottle and make baby root for it just like I would at the breast, tickle their upper lip, up. And then when they finally open wide, that almost 90 degrees, like the baby bird or as wide as a yawn, then the bottle nipple goes in, and it only flows when they suckle. And if they pause, which is normal, and they will pause, the bottle tilts down, no milk is flowing, they start suckling again, we tilt it back up. There is no gravity, glug, glug, glug. And I sometimes will take a bottle with a nipple on it, and if you hold it like this and barely compress, it just pours out. Sometimes you can take the bottle and go like this and it's already dripping. We don't want any extra help. So I tell the parents, I want bottle feeding to be less easy, less fun. I want it to be as much work or harder or feeling awkward. I want the breast to be the place where they just like, this is where I want to be. There's also some data, and it may argue that every baby that's bottle feeding needs to be doing paced bottle feeding, which is just that the larger the bottle size, the higher daily intake of the baby. And then if you put pumped breast milk in a bottle, those babies have a higher growth velocity, which is not necessarily a good thing. So we know that babies take more milk when it's in a bottle, and we don't necessarily want that for those the spiral that we talked about earlier, right? I also always get asked about tongue tie, and I think when I went through residency, we never clip tongues, it does not matter, that's an old wives' tale, etc., etc. That's what I was taught. However, I think that there are some tight lingual frenulums. If you talk to the pediatric ENTs, there's a blip of 3- and 4-year-old kiddos that if they haven't had it clipped as newborns for feeding problems, get it clipped a little bit later for speech difficulties. There's another blip, do you know what it is? It's so cute. Teenagers. And it's because of kissing and eating ice cream in public and sort of that body dysmorphia thing. So it's true that once you get past newborn feeding and speech, that there's probably no functional reason to do it, but there's a little tiny blip of who gets it done as teenagers. I would say that tight lingual frenulums do exist. It's fairly common, and it only needs attention if that combination of mom's breast and nipple areolar complex and baby's jaw and how far and how much mobility of the tongue they have, if that combination is causing problems such as inability to sustain a latch on the part of the infant, or no matter what we do with all of our tricks, still having pain, or mom has milk there and it is taking the baby 40 minutes to get it out, or mom has milk there and baby's weight is not where it should be, so they're having trouble transferring the milk. Those are the reasons that I would consider clipping. I call these my rules of tongue. There is no data to support clipping labial frenulums for breastfeeding of any kind. There is no data that says that a posterior tongue tie is a different entity, and there's no data to support clipping posterior tongue ties that are submucosal. If I had a baby like that and I really thought it was impacting feeding, they would go to pediatric ENT and probably have what's called as a Z-plasty, which is not what we're talking about here. We're talking about little quick scissor, boop. It takes longer to talk about it and consent them for it than it does to do it. When I'm doing my newborn exam, take my pinky, gloved finger, and just slide it under the baby's tongue, in addition to checking their palate and all the other things we look at in the mouth. And I want to get about a centimeter that just goes whoop from one side to the other. If I feel a little speed bump, then I'm like, okay, could be. So then I'm going to pay attention to how the feeding's going, how the transfer's going, all the things that we just talked about. And if it's one of those where I have to take my finger and take it out of the mouth to get to the other side, that may be, if I'm identifying breastfeeding problems early on, that may be somebody that I would recommend clipping even before they go home from the hospital. I would be extra careful, and by the way, I'll show you some trustworthy, I think, tongue tie sites in a second. I would be extra careful if I'm hearing somebody recommend that they need to drive a long distance. There's a certain lactation provider in Charlottesville, for example, that only sends people to this one dentist in Maryland. Not sure about that. I would avoid laser procedures, and the only complications, knock on wood, that I have seen from frenotomies have been laser with severe burns that are extended way beyond where the frenulum is, i.e. too much energy went to that area, and oral aversion. So I think the going convention right now is scissor only, not lip. There's no such thing as buckle ties. If you're hearing that, that makes me concerned. And no stretching as exercises, no data to support that. And again, painful, hurts. When would we ever do that to an open wound? No to the no. Here's some trusted resources. I mentioned Academy of Breastfeeding Medicine actually has a clinical protocol about tongue tie. Cochrane Database Review, AAP, has some statements about it. ARC has a comparative effectiveness review of which I was a part, so that's a no. Another quick thing that I think every doctor needs to know, regardless of what your particular specialty is that most medications in mother's milk are fine. It is important to have a trusted lactation pharmacology site to look up these medicines, because you'll find that the PBR and micromedics will just, if there hasn't been a test, will say don't use it if you're breastfeeding, and most of the time that's not true. We're actually working with the government and FDA to change the wording of those things to make it more breastfeeding friendly. If I could give it to the baby if they were sick and needed it, it's probably fine. If it's not well absorbed, for example, IV contrast, then it's not going to get into the baby's gut and then get absorbed, because I'd have to give it to the baby IV. So none of this pumping and dumping if mom has radiologic studies. The only exception would be nuclear medicine studies. When you look at those lactation pharmacology sites, We want a site that looks at the relative infant dose, that's studied the milk to plasma ratio, that's taken all the case reports of mothers who had to take this medication and continued breastfeeding about what, what the concentration in baby's blood was. We want to know, is it lipophilic? How big is the molecule to know whether it can even cross from the breast into the milk? I always talk with parents, less is more. And so if there is a safer alternative, for example, with SSRIs, we have like 30 years of data for Zoloft, for sertraline, for example, then I might pick that one over the brand new whatever because we have 1 year of data for that one. But it's you can always have those conversations. And then, of course, weighing the risk of benefits, but weigh the risk of not breastfeeding in that equation, right? So Infant Risk is a great app. I have it on my phone, and it gets updated continuously. This is out of Texas Tech, Thomas Hale's work. It's excellent. It'll actually give you these little check marks, so at a glance. And the other thing you can do is go online to LactMed. I took the picture off because the LactMed app is no longer supported, which is a loss because that one was free. But LactMed online is a part of the NIH ToxNet. I also put a couple slides in here just to think about from our standpoint, what are some other things we can do to help with breastfeeding? Think about the environments that you practice. Are we providing culturally and ethnically competent care? By that I mean not assuming based on age or skin color or previous experiences with breastfeeding, or I had this one mom who had a tattoo of a bottle feeding baby on her arm. Just don't assume and have the same conversation about we know that this is recommended and how can we help you, etc. And so think about that. Think about the images that you have in your offices and your public spaces. Think about educating all of your coworkers. So we have part of our UVA breastfeeding medicine program's mission, even though it's not on paper and it's not our job, is to support lactating women who work for our institution. So I'm on these work groups and these committees and I'm like, yes, they want a computer, get a computer in there and make sure this one has a sink, and just advocating, because if we can help our own get through this, and by the way, being a healthcare worker is a risk factor for early cessation of breastfeeding because we are not good at making this okay. So make sure you're doing all of those things. So here's a summary. Here's my little baby Stella, who's now in college. And I walked around the corner after her preschool orientation and she was feeding her baby on the couch. And just think about how every child should grow up thinking that this is how you feed babies. We actually did a study with med students about how many baby dolls in the stores came with little plastic bottles, and it's an alarming number. So we didn't learn enough. Some of it was wrong. It's important, and they usually don't need formula if we can offer optimal support. Look at the baby-friendly literature on that. If you change what you're doing in the hospital in those couple of days that they're there, the rates of breastfeeding for those families are higher at 6 and 12 months. So you either get it going or you don't. And if we provide optimal support, they get it going. Feed on cue, watch baby, not the clock. We can predict who could have problems and we can help them and give them extra support. We can tell if the baby's getting enough and we can reassure the families. We can help moms who are having pain, both convince them that something could be tweaked. I call it fine-tuning, or just a little adjustment here or there. Help them experience that feeling when it feels better. Scissor frenotomy only after a feeding evaluation if it's a clinical functional reason, and most medications are fine. So we have a big role to play. I've included some other what I feel like are really useful clinical resources. I want to put a plug in for Academy of Breastfeeding Medicine. It's a physician organization with over 1,000 members worldwide, excellent clinical protocols that are evidence-based. They've met the criteria to be included in the National Clinical Protocol Database. They are excellent. It's painstaking work. I authored one and I'm just like, I think I won't do that again because it wasn't my jam. American Academy of Pediatrics has a section on breastfeeding. I'm on the executive committee for that. And both of these organizations have trainee and student rates that are very affordable, and lots and lots and lots of CME offerings and maintenance of certification. And then for any of you that are breastfeeding or have loved ones that are and are in the healthcare field, for doctors specifically, there's Dr. Milk, and I prescribe this now to our resident and faculty, new mamas and families, because again, being a healthcare provider is a risk factor. So I will leave you with peace, love, and breast milk or colostrum and this beautiful picture by Alex Gray. And I'm happy if there's time to take questions, but otherwise I'm just so happy to be here and thank you for having me.
We have one